Good morning, everybody. My name's Bronwyn Edwards from Roses in the Ocean. Welcome to today's live webinar around Feedback Loop number 2 for the Nepean Blue Mountains. I would like to acknowledge the traditional owners of the lands on which we're all gathered today and pay my respects to the elders past, present and future. And of course, in particular, we acknowledge today the Darug, Gundungurra, Wiradjuri people of the Nepean Blue Mountains region. I'd also like to acknowledge people with a lived experience of suicide. For those of you who've joined us today online, thank you so much for bringing your insights and your courage to this very important co-design process. To all the people with lived experience in your broader community as well, we acknowledge those people, as we do our health professionals, and acknowledge that many of our health professionals come to work with a lived experience as well. And for those who don't, you know, everyone is incredibly impacted by suicide. And of course, you have an enormous amount of passion around this particular topic, which is why you've joined us today. So what I'm going to do is I'll just share my screen now and step you through where we are at, what we've learned so far, and the areas that we're really looking for your further input through the survey that will be available after this webinar. So bear with me just for a moment while I share my screen and we will get underway. All right. So hopefully that's all clear for you now. So this is the process so far. Just to remind you and recap, if anyone new is joining into this process at this point, people have had access to the orientation webinar and information pack, Ministry of Health's Statement of Requirements. We've run focus conversations, so small focus groups with our lived experience representatives and a number of health professionals. We've then had some time with the lived experience people on their own as a group. That went in, then all of that information went into 2 different feedback loops that formed feedback loop number 1. We've then had a session with our health professionals, just with them together, and now here we are in feedback loop number 2. So that's where we are in the process. So the purpose of the session today is to bring you up to speed with where things are at, and then gather broader insight regarding this process through the survey that will follow this particular webinar. All right, so responses from the lived experience feedback loop, just a very brief summary for you. We had 10 additional people respond to that survey. Lived experience respondents agreed that the slides presented mostly resonated with their own experiences and needs. We gathered some additional perspectives from people. So there was somebody who completed that survey who had presented to a community mental health centre outside of your actual catchment area, which had led to an involuntary inpatient admission. Another person that had negative past experiences of accessing ED, and that they resolved that they would never do that again. And another perspective from a carer, experience of a person unlikely to seek support. Some key things, some additional things I guess that were contributed through that feedback loop was just that need for listening, you know, really needing a space where there's just another person to talk to without anyone trying to minimise their feelings or fix things or call emergency, just that place where people could be deeply listened to. A non-clinical space to be seen as a person in distress, not as someone who's unwell. And that staff are not separated from visitors by glass. So it was a really compassionate and warm space where people could interact, staff could interact with the guests very freely. Lived experience respondents all agreed with the draft values and principles presented, but there was a point of interest around the need to unpack what is meant by safety more, which is something that we'll address in a further session together. Feedback provided around ideas for the safe space that were most important or not already captured. So there was a lot presented in those feedback loops around the ideas for a safe space. The ones shown here are just ones that were deemed as most important, or if there was anything new. So someone on arrival to say, "I'm glad you came," is really important. Being able to use your mobile phone, staff having a lived experience and comfortable sharing their experiences. So it spoke about the suicide prevention peer workforce being trained to a point where they're really comfortable sharing appropriately and at the right time, being able to bring their insights to their conversations, and particularly their lived experience of recovery. There's a lot of people asking that the safe space is actually a house. There's a comment here that a relocatable house is fine from somebody. That staff are committed to trauma-informed practice, and that they do not hold negative attitudes towards people who experience chronic suicidal ideation. So really speaking to the fact that the safe space is somewhere that somebody can come as often as they like and as often as they need to, if that becomes part of their way of staying safe, then that's a good thing. And that staff have diverse cultural backgrounds as well as LGBTIQ, young people. So there's a really nice diversity within that peer workforce. That peer workers, health and social workers could all be involved. Somebody highlighted there could be potential issues with hierarchy. So that would be something for us to talk about in terms of the staffing and what that model looks like, how those people are engaged and at what point. Separation of people with thoughts, behaviours where harm is towards self from people who are experiencing psychosis-related behaviours. So I think this just speaks to the physical layout of the space, so that there are areas where people can have privacy, and if you're just needing to be on your own in some really quiet space, that's possible, understanding that there will be people at varying levels of distress that come. The GPs have information and share it with their relevant patients, especially those that would never enter an ED, but just so that GPs are really on board and connected with the safe space. That safety and risk harm minimisation are a priority. Questions around which organisation manage the spaces and the process for referrals and overflow. So question people are, this person was really looking at, well, what happens if the safe space is really, really busy and there's just not enough staff to have someone else? What happens? What's that relationship with the hospital, with other services, and how would that work? And someone, people just wanting to make a cup of tea and have some food with the peer workers, games, books, sensory items and what have you. Now, from the responses from the health professional feedback loop, we had 7 additional people respond to that survey. They all agreed that the slides presented reflected their experiences, with additional feedback provided around issues and challenges with the current services and needs and ideas for a safe space, in addition to those identified by people with a lived experience. So in terms of people's comments on the health professional feedback loop survey around current issues and challenges, there was more people sharing around feelings of invalidation or shame in accessing support, that they're very aware that that's how a number of the people that they support are feeling. People are scared of being locked away. This missing middle that we hear spoken about quite a lot lately, between that primary care and ED, that's a real an issue, that there's nowhere to manage complexity and prevent distress and encourage a healthy lifestyle in the current environment of ED. So people speaking to the fact that they're wanting to provide this additional care and support, and it just wasn't conducive to doing that. That there's no appropriate after hours community support except for hospital-based services, so that was a current issue, and that people are triaged, assessed and reviewed endlessly, each new clinician needing to take that person's story, which is quite challenging for the person having to provide it multiple times. There's no sense that people have arrived somewhere that is going to help them. So it's speaking to that helplessness that aligns also with the comments from the people with a lived experience. That there's a lack of knowledge and training in supporting someone with distress for the staff who are in ED. That there's not enough access to community psychiatry in the region. That services are too clinical, the environment's too stark, and the human element is removed. A lack of government funding was highlighted as a current issue and challenge, risk-averse practice, and too much focus on the biomedical. So they were some of the comments made through that survey by health professionals. They went on in terms of needs and ideas. Some of the health professional comments were that the safe space needs to be a welcoming, warm and validating experience, have trained peer workers, advice around issues that trigger distress, so relationships, schoolwork, planning, so speaking to having really solid training for the suicide prevention peer workers, a secure private outdoor area to connect with nature, and adjust the environment's look and feel so that, you know, the nice lighting and music, the temperature, preferred sensory tools were made available to people, offer choices of refreshments and welfare items, a regular home. So once again, this real theme is coming out. People are asking in your region for a home. Acceptance that someone can communicate, engage as much as they're prepared to. Located close to existing youth-friendly services for a warm handover of care, wraparound care, and considering how a person is transported, you know, acknowledging that police and ambulance is not ideal. So how would people come to and from the safe space if they didn't have their own means to do so? So in terms of safe space elements, we are seeking endorsement and further input in this feedback loop on values, the location of the safe space, connection pathways to the safe space, outward connections and partnerships, staffing and workforce development, and we'll go through these in more detail. And then in the co-design session 3, we'll be focusing more on service model, physical environment and accessibility, and governance. Now, we held a group health professional co-design session. Unfortunately, a large number of the health professionals weren't able to join us, so I'm really hoping that they can all watch this, either be online now or be able to watch this webinar once we get it up on the landing page this afternoon, and also contribute to the survey. What I would really ask is that every single one of you make sure that you send this webinar link and the survey link to everyone you know in your networks, because we really do want that broad community consultation. So please send it to all the people that you're working with. Let's get their feedback. And if you're watching online and you're a lived experience person, please send it to those in your networks as well. And just to your general community members, regardless if you're involved in sports clubs or whatever it is, through your school communities with children. Just let's get this out far and wide. That would be fantastic. Okay, so this is what we explored at that health professional co-design session. The location of the safe space. So determining a suitable location is going to be difficult, is what we've been told, because every area deserves to have a space. There were some competing views around the most ideal location. Some suggestions included Windsor, Penrith and Lithgow. The highest volume of demand was likely to be in Penrith, we were told, but people from the Blue Mountains will feel missed out. And there was acknowledgement that the large region will bring challenges, requiring many people to travel by car to access it. So there was conversation around how do you position this safe space where there is some public transport, but recognising that in your region, there's a lot of people that live, you know, a good drive away from anywhere that they could access help. So there's very strong feelings from the health professionals involved that the safe space should not be located on hospital grounds. They believe it will be a deterrent to people accessing it. And important considerations for a suitable site include ideally a house, disability access and proximity to public transport or other transport options. Now, in terms of connection pathways to and from the safe space, there's a lot of discussion here. It needs to be communicated and presented differently, that it's not a clinical space. So right up front, it was about, well, how do we actually make sure that the right information is shared and people actually know what this safe space is about? It needs to overcome fear that people who go to hospital believe they'll be locked up. In limited hours, the question was asked, what happens if someone isn't ready to leave the safe space when it's due to close? And it's a really important thing that has to be discussed further. PHNs are a key resource in sharing information and awareness of connection pathways. So potentially there's a role there for the PHN in connecting the safe space to other services. needing to connect with grassroots providers, CMOs and groups, and past success with dedicated roles to promote new service and build relationships. So really tap into those great community relationships and bonds that are already in existence to help try to connect people to and from the safe space. Face-to-face engagement might be required with some services to build confidence. So, you know, there's potentially a role for the promotion of the safe space and for time to be invested in those that you really want to be connecting in and out with, so that they really understand what the safe space is, the training that the peer workers are provided with, what it offers people, so that they then feel confident in connecting people with the safe space. A potential partnership with a community transport provider helping people get to the safe space was an idea that would be great to be able to explore further. Recognition of growing number of community-led initiatives that might dovetail in, connecting with carers and loved ones and using their personal resources to support inward connection, and acknowledge difficulty with small workforce of having staff outside of safe space transporting people. So the LHD is being funded for 1 service manager and 2 FTE worth of suicide prevention peer workers. So how do you actually manage that workforce, and what will be really feasible in the beginning stages with that amount of staff if someone is transporting or accompanying somebody to another service needs consideration. In terms of staffing and workforce development and support, staffing profile of 2 FTEs, I just said, the suggestion was from the health professionals that they should aim for a number of part-time roles rather than 2 full-time positions, just so that you've got greater diversity, more coverage, availability over the week. You know, citing that you're likely to require at least 2 staff working in the safe space at any given time. Acknowledging that it's tough work at times and potential burnout of the full-time roles. So really recognising that sharing the role of being a suicide prevention peer worker would be of benefit for a number of reasons. It's worth considering if opportunities to combine resources across the safe space and the suicide prevention outreach teams, those spot services that are also coming to your district. So whether or not the peers are, one of the conversations was, would the peers actually be able to potentially rotate between being part of an outreach team 1 week and then, or a month, and then into the safe space for a month, highlighting the need for that continuity as well. So the rostering would need to be considered carefully. So here, yeah, rotation can help to ensure people get a break, improve diversity, but the rostering would need to be very carefully managed. Need to prioritise the safety and support of peer worker roles, and a range of proposed training seemed acceptable that the Ministry of Health has suggested. The additional suggestions around art of listening type training activities. So they were the suggestions in terms of staffing and workforce development. All right, so now what has been agreed on so far? So we've used a traffic light system here, and this helps us to determine what is in full alignment between the Ministry of Health requirements, the lived experience representatives and the health professionals. Anything in orange means there's further discussion to explore. There might mean that there's some divergence there, or it's simply an area that needs to be unpacked a bit more to get some detail. And red equals out of scope according to the New South Wales Ministry of Health Statement of Requirements. Now, with the values to inform the model, you've got there on the left-hand side those that came from the initial co-design process at the end of last year that the Ministry held with all LHDs and a range of participants. And then here on the right-hand side are the values that have been formulated to date, still got work to do, but by the lived experience people, and have been approved through those feedback loops 1 and 2 by health professionals as well. So there's general agreement with the values, but there's just that point that I mentioned earlier, we need to further explore what people are meaning by the term safety when it comes to a value, and what implications does that have for the actual model, the service model. When we look at the location of safe spaces, you'll see that there is really nice alignment across a whole range of points. It can be located on or off hospital. It's come very loud and clear that people are wanting this off the hospital grounds in your region. The only things that there were multiple locations within region that were suitable and desired. And at the moment, having multiple safe spaces is out of scope from the funding that's being received by the LHD. But obviously, that's definitely a blue sky dream, isn't it, to have multiple safe spaces available. And just not on hospital grounds there. That seems to be definitely what people are asking for. What is going to be the issue is finding a space. So that will have further discussion. So what needs to be further explored around the location is, where is it actually going to be? So which town, where in the region will it be? How close will it be to an emergency department? And if an actual house, which everyone's asking for, if it can't be sourced, what are the other options? So these questions here will be in the survey that will be available for you all to complete after this webinar. Now, when we looked at connection pathways to the safe space, the statement of requirements says that there's no requirement for people to present to an ED prior to coming to the safe space. The guests don't have to undertake any assessments or meet eligibility criteria. There's a no wrong door approach, and that the service is promoted within local communities so that people are aware of it and what it can provide. Really nice alignment everywhere. You can see a couple of areas there. Suggestion that there could be a dedicated role to promote the new service and build relationships. People were talking about a part-time, just a 6-month role to really get out there and really actively promote the service. And a question around how could people maybe be transported to and from. So in the outward connection section, the only area there in the orange is about follow-up, that people wanting to talk more about what could follow-up look like and what would you like the safe space to be offering in terms of follow-up for guests. So when we come to the actual questions that we need to, or things we need to further explore around connection pathways to and from, it is about promotion and partnerships in the community and with other services and organisations. So what might they be? How people will be connected with or arrive at the safe space, arrangements and protocols required to support connection to and from the ED if that's what people want to have happen. So what does that look like? So that talks to your governance structure. What happens if someone isn't able to be supported at the safe space or isn't ready to leave when it's closing time? So you'll see that came up a little bit earlier. So that's something we need to unpack together. And what happens when someone leaves the safe space, including follow-up? So these will be things that we'll be asking for you to think about and provide us your thoughts in the survey. When we come to staffing, there were a couple of out of scope comments here, as you can see. Equal number of peer workers to participants. So that's purely only out of scope because of the funding, because of the budget. So at this point in time, there is one service manager and 2 FTE worth of suicide prevention peer workers. So that doesn't necessarily mean that there'll always be an equal number of peer workers. Access to a service that involves peer workers and clinicians. So this is where it will be interesting for you to explore as a region the suicide prevention outreach teams that are also going to be designed, co-designed and established within your region. What is the relationship with those with the safe space? Because the Ministry of Health Statement of Requirements outlines that the safe space is to be non-clinical with no clinical services provided within it. So what does that mean for the suicide prevention outreach teams, and how might there be a relationship there potentially, or how will you connect a guest to a clinical service if that's what they need and want? In terms of the orange, for further discussion, is around that diversity of workforce and the collaboration and those connections between peer workers and clinicians. So in terms of workforce development and support, there seemed to be very nice alignment between what the ministries are requiring and what everyone else is asking for in terms of safety, supervision, debriefing of peer workers being a priority, relevant training, trauma-informed. So we all seem to be on the same page in that respect. So on the survey, we'll be asking you to explore further the proposed staffing model with allocation of 2 FTE and how you might actually utilise that 2 FTE. The training and support required for the suicide prevention peer workforce. The statement of requirements outlines essential and optional training. Is there anything else, anything in particular that you think is really necessary? Maybe particular priority groups within your region. What else do we need to know about? The diversity of experience and background required of the suicide prevention peer workforce. So the ministry's requirements state that they will be people with a lived experience of suicidal crisis and or attempt. Is there something else? Is there anything else that you're looking for to get that diversity of peer workforce? And what are the functions of the service manager role? So love your thoughts on those particular areas when you complete the survey. So just in summary, the Feedback Loop 2 survey questions will be asking you, to what degree do you endorse the slides that you've just seen? Is there anything in particular that you don't agree with? And do you have any additional input or suggestions relating to those 4 areas there, the location, the connection pathways, staffing and workforce, and the physical environment and accessibility? A lot of that work was done in the Feedback Loop 1, but just if there's anything else around that physical environment, that would be helpful. So what remains to be explored and agreed in co-design session 3, we will be inviting equal numbers of lived experience people and health professionals, and it will just depend on people's availability, but also us ensuring that we get a good diversity within that group of experiences as well. We will be talking about the findings from this feedback loop and the survey. We'll also be focusing in on service model and governance. We'll be presenting scenarios that will test the potential service model, but also test how can we honour the values and principles of the safe space in this particular scenario. So that's the work that will occur in the next session. In terms of the service model, there's a lot of alignment at this point in time. There was a comment in the health professional so far around the availability of community crisis service. So we just need to investigate that a little bit further, but I suspect that's turning towards 2 things, your suicide prevention outreach teams, but also in people understanding the level of training that the suicide prevention peer workers will have and their ability to actually support someone who does come to a safe space in crisis and have those really great governance protocols in place to connect to clinical service and support if that's required as well. In co-design session 3, we will explore also how guests and carers, families and friends will be supported. So what role does the safe space play for those other people that are very important parts of that scaffolding of support? In terms of the physical environment and accessibility, around looking at when it's actually going to be open, so as much coverage as possible. The lived experience people have suggested perhaps sort of a late afternoon through till midnight, and so need to work out what's going to be possible there, and that will obviously be determined also by where this safe space ends up being located, and needing to explore what is meant by the term safety. So we'll be exploring in that session 3 the opening availability hours, style and layout of the space, specific needs of priority groups. This is very, very important, and it will how to meet those, but that will also inform your staffing diversity mix as well, and considerations for ensuring the safety of guests and staff. You know, understanding that people might be coming to the safe space at 11 o'clock at night and wanting to make sure that it's a safe place to actually get to in the first place. From a governance perspective, the lived experience people haven't really explored that as yet, and there hasn't been a lot of exploration to date around governance. So we know that there needs to be clear governance and reporting lines within the health service to provide oversight and support, a clear process to actively support the peer workers, when and how additional clinical supports may be needed. Lots of opportunity for lived experience involvement, that continuous improvement and reporting. So we'll need to be looking at that in co-design session 3. So management of the service, how's that reflected in governance? What are any key risks that need to be determined? The protocols to support that connection to and from, good feedback loops and opportunity, and how do we collect and report data? What does that even look like in a safe space? And how does that get reported back to the Ministry of Health? Right, so I'm just about to come back to the screen. Just next steps, you will find the links to the recording of this webinar as well as the survey on the Roses in the Ocean website on your landing page. So it's simply rosesintheocean.com.au / and then Nepean Blue Mountains LHD. The survey will be open until the 19th of September. So please, please, please get on and respond. Get it out to as many people as you know so that we can get a good response back to this survey. And then the co-design session number 3 is on the 21st of September. Okay, I'm going to stop sharing my screen and come back in case anyone has any questions for me. So you can either pop them in chat, or there's a Q&A button there as well on your screen that you can ask a question of. Okay, well, at this stage, it doesn't look like anyone has any questions, which is absolutely fine. There's a lot of information to take in half an hour of me just talking to you and looking at lots of slides. So what I just encourage you to do is make sure that we get that survey well distributed. Yeah, look, there's a comment here from someone saying just disappointed in the poor response rate from both health professionals and lived experience people. Can you please tell me how our response rate compares to other LHDs? Look, we're a little disappointed as well. Absolutely. If you compare to one of the other LHDs where we've run this, we had sort of 16, 20 people on webinar feedback loops and what have you, and upwards of 20, 25 responses to feedback surveys. So yes, response is down here in the Nepean Blue Mountains at this point in time. It's probably why I'm reiterating so much to please, please, please get this survey out, because we really do want to have more people engaged. However, those who have engaged have been absolutely spectacular. Really amazing insights, very passionate, sharing a lot of really, really useful information. So thank you all for those of you who have been able to participate so far. All right, well, look, I'm going to leave it there. There's no other comments coming in at this point in time. Please take care of yourselves today. Have a great day. Thank you so much for tuning in this morning, and we'll get these links up on the website in the next few hours for you. Okay, take care, everyone. Bye.